Hi, my name is Anastasia Lynge, and I'm going to be presenting today on dissociative experiences in survivors of trafficking, including a clinical overview of best practices and services that we can provide to survivors in the clinical setting. So just to kind of get us oriented to the space, I like to always include a roadmap of where we're headed. I'm going to start by grounding us in some objectives for the day, including just hopefully some learning outcomes takeaways for this presentation. I'm going to include a little bit of information about who I am and what brings me to this work, a theoretical orientation to really get us grounded in some of the more conceptual parts of the services that we're providing and things we see in the survivor community population. And then we're going to talk about some treatment implications. So really practical, what can we do when we're providing services and what modalities can we be drawing from. I'm going to wrap up the presentation today by talking about liberation psychotherapy, which is a public health approach to working with survivors of trafficking that we can incorporate into our clinical models. And then we're going to end with some conclusions just to kind of sum things up. So the objectives for today's presentation are to explore the theory of structural dissociation in the context of human trafficking experiences. I'm going to talk a bit about what that is and include some definitions and some history about where that concept comes from. We're also going to discuss promising practices in the clinical treatment of human trafficking. And we'll identify the role of a public health approach within the larger clinical framework of liberation psychotherapy, which is a treatment approach that's used pretty widely in a variety of mental health settings. But I want to talk today about the specific implications for using a liberation psychotherapy approach with survivors. So who am I? My name is Anastasia. I recently graduated the Smith College School for Social Work with my Master of Social Work degree back in August. I am a 25-year-old white queer femme. I am currently a program coordinator for Verite, where I support a variety of work streams related to forced labor supply chains. I also work independently as a consulting researcher and policy analyst for anti-trafficking organizations. So, anything from mental health direct service organizations to academic institutions and nonprofits. I previously worked in the clinical space as a therapist and case manager for survivors of trauma, including survivors of labor and sex trafficking. I have a pretty broad range of experience within trauma services that goes beyond the scope of trafficking, but that'll be primarily the experience that I draw from today in terms of my past clinical work. And I also have lived experience of familial and state-facilitated sex trafficking, as well as consensual sex work. So I'm bringing a lot of my own kind of personal ties into this work as well. So leading into that, I'm not really a person who uses storytelling a lot in my work, but I did want to include some information about what brings me to this topic and what I personally feel like I have stakes in. So I came out of my own lived experience and was really looking for a lot of long-term supports. The things that I needed the most support with when I was getting out of my trafficking were housing and economic resources, and I really struggled to find referrals to services that were comprehensive and that were also long-term. I was being referred a lot to short-term services, short-term shelter programs. I didn't meet the criteria for a lot of services because of my own kind of psychological stuff that was going on, as well as, being going to school in one state and like residing in another state. And it was really, really complicated. And so I ended up having to kind of piecemeal my services together and like get one resource from one place and then one resource from a different place. And there were a lot of cooks in the kitchen. as I went on in my own kind of recovery from trafficking, I started to work with other survivors who were more recently coming out of situations, and similar things would come up. We would refer survivors to really short-term services or to these like graduation model services, which I'll get into in a minute. And a lot of times survivors were not getting the kind of long-term support that they needed to obtain things like a secure address, a job, education, clinical services that actually aligned with what was needed at the time or what was wanted out of clinical services. So I really started to question, why is this service model so focused on short-term options solely, and there's like no long-term thinking really at all. And as I started to get into other types of mental health work, including, long-term psychotherapy, I noticed that the service delivery model there was very different from what we use for survivors of trafficking, both from what I came to understand in my own lived experience, as well as what I had seen as a provider. So that's me, that's my background. I'm going to move into discussing some of the kind of more theoretical concepts next. These can be just really helpful grounding, and also can be a way for us to develop a shared language that we can use to talk about some of the things that we're seeing in the survivor population generally. So I wanted to start off with this quote by Sandor Ferenczi. He was a psychotherapist in the early 1900s, mentored by Freud, and he wrote an essay where he discussed a phenomena that he witnessed in many of his patients, confusion of tongues between the adult and the child. And one of the quotes that I love from this essay is on this slide. It says, "If more love or love of a different kind from that which they need is forced upon the children in the stage of tenderness, it may lead to pathological consequences in the same way as the frustration or withdrawal of love quoted elsewhere in this connection. The consequence must needs be that of confusion of tongues." So this phenomena that Ferenczi termed confusion of tongues is what we now refer to as structural dissociation, right? It's the separation of oneself from one's own memories. And this can make it really hard when we're in the clinical setting to discern what's happening with the person we're serving and what's happening within ourselves. So I wanted to put this quote here because 1933 was 90 years ago exactly. People have been talking about this phenomena for a while, okay? Like this has existed in the literature for almost a century now. Freud also talked about similar things using, different terms, but this is something that we've seen come up time and time again, that providers have struggled to kind of name and put words to and understand how to respond to people who experience themselves as being fragmented or who experience their memory as being separate from their lived experience. And that's something that we see a lot in survivors of trafficking. So something that is both necessary for structural dissociation to occur, which we're going to define structural dissociation in a minute. But this phenomena, betrayal trauma, is, I would say, inherent to all experiences of trafficking, right? So betrayal trauma is defined as interpersonal trauma experiences where the perpetrator of the act is an individual who is trusted and needed by the victim. And this, when we hear people's stories of trafficking, is something across the board that many folks report. The betrayal, when we talk about fraud, force, coercion, those are forms of betrayal. There's a loss of trust there. And then there's this like need to stay in the situation because of grave threat to a person's physical or mental well-being, and material reality. So some examples of betrayal trauma in human trafficking that we often see include trafficking by a partner, a community member, family member, or a friend, a lack of community response to experiences of trafficking. We talked to survivors who lived in communities where it was pretty well known that they were being trafficked, and there was no response or very little response from the surrounding community. And there's also a lack of sustained support after an experience of trafficking that many survivors report, either because people don't know how to respond to the situation, they're not educated about trafficking, or because they just don't want to tolerate the idea that a person that they love or care about has been trafficked. So in terms of the theory of structural dissociation, this was something that three scholars, Nijenhuis, Onno van der Hart, and Kathy Steele, have developed, and it has really, taken off in the last 25 years. So these three scholars define three types of structural dissociation of the personality, and these are not, based on levels of severity. It's more based on levels of fragmentation. And the hallmark of structural dissociation is that there's this mechanism involved where a person stores memory, traumatic memory, in one part of the brain, and then stores the emotions and feelings associated with that memory in another part of the brain. So those two parts of the brain become separated from each other by the trauma. And there's this need for integration to occur for the person to really grapple with the full reality of their experience or the full weight of the experience. So when we're talking about trafficking, we're really talking about secondary and tertiary structural dissociation. Primary structural dissociation most commonly develops after a single incident of trauma. So something like a car accident or a single assault. And that can result in a diagnosis called post-traumatic stress disorder that I'm sure many of us are familiar with. So I don't generally like to use diagnostic language, but for this, I think it's helpful because oftentimes providers are a bit more familiar with the diagnostic categories than they are the terms of primary, secondary, tertiary. In survivors of trafficking, we're talking about people who have experienced complex traumas over the course of time. So oftentimes survivors develop secondary structural dissociation, which develops after repeated, often complex trauma. And this can happen in childhood, adulthood, or throughout the lifespan. It's not limited to an age. So a lot of times the diagnostic language that we use to categorize this experience is complex post-traumatic stress disorder, which is not in the DSM-5, but I think is pretty commonly used in our vocabulary as service providers now. Borderline personality disorder, and then something called other specified dissociative disorder, which is sort of a catch-all for folks who have a bit more severe symptomatology than post-traumatic stress disorder, but who don't quite meet the criteria for other dissociative disorders or personality disorders. Tertiary structural dissociation can really only happen after a child has survived a series of complex traumas. We see this most often in survivors of child trafficking, both labor and sex trafficking. And this results in something that we refer to now as dissociative identity disorder. I'm not super fond of that diagnostic category myself. There's a lot of controversy that surrounds it, but within tertiary structural dissociation, there is a higher degree of fragmentation that can lead to people developing, different parts of the self that maybe have their own kind of like thoughts, opinions, experiences, and ideas. So what are the treatment implications for all of these categories? Now that we have some theoretical kind of backing language to use, how do we use this when we're working with populations who have survived different trafficking experiences? So how did we get here to our current service delivery model, right? Like what is the current understanding of our services? So there is no identified best practice for serving survivors of human trafficking in the therapeutic setting. This is largely because, like many conditions of the human experience, trafficking is very unique to individuals and can look a lot of different ways, right? And this is something that we know and that has been very well documented. Previous treatment approaches have emphasized the role of behavior modification, particularly through the use of cognitive behavioral therapy, which is at right. This is a treatment model that has shown great utility for a variety of conditions ranging from substance use disorder to obsessive compulsive disorder and other anxiety disorders. Treatments also tend to emphasize comorbidities. Speaking of these other diagnoses, oftentimes we emphasize the treatment of substance use and anxiety disorders over the treatment of complex trauma and chronic dissociation. And one of the biggest things that leads to this overemphasis is really a lack of training. It can be really difficult and also very expensive to obtain specialized trauma treatment. Many clinicians can't access those resources. And oftentimes supervision, like adequate supervision, is not available to newer clinicians who are looking to gain that type of experience, just because of the lack of training and the lack of knowledge, which is something that we definitely need to be thinking about of how do we increase that. Ongoing treatment of trafficking survivors is complicated by the use of the graduation model of services. This is very popular in the United States. I have worked within this model before myself, and this is a model of treatment that we do not use anywhere else in the mental health sector. So the graduation model, we essentially give survivors who are typically very early in their healing journey, right? Folks who have just gotten out of their trafficking experience or who are, maybe less than 6 months out. We give them really comprehensive residential services, right? Like a lot of times this is a program that has a confidential location. There's in-house treatment teams, in-house medication, referrals to physical health services when needed, substance use treatment, job search services, life skills, professional development, like all of it. We give people a year and a half and then we graduate them and we tell them, you are better now. You don't need services anymore. So for folks who have been in their trafficking experience for 10, 15, 20 years, a year and a half of treatment is not even going to scratch the surface, right? Because we're talking about 20 years of continuous trauma or, a decade or, what would it mean to treat survivors holistically throughout the lifespan, all while maintaining a strong continuum of care? And we don't tell people, you're done now, you're graduated, and you shouldn't need services anymore. I've also worked in substance use treatment, and this is not even a model that is used in the most intensive types of substance use treatment, like in residential facilities. There are different tiers of residential facilities, and folks often spend years working their way through those tiers until they feel ready to live independently or live with, a roommate or something like that. So it's very much against kind of that theoretical orientation that we just talked through to do this graduation model. So what are some of the alternatives of evidence-based practice? There are several different treatment modalities that show promise in working with survivors of trafficking. And of course, these are going to be tailored to the individual, right? So we have internal family systems, which has been written about pretty extensively. I would say that Janina Fisher is really like the big name in IFS right now. Somatic experiencing, which was developed by someone named Peter Levine in the late 90s. And then we also have dialectical behavioral therapy, which has a lot of overlap with cognitive behavioral therapy, but it's more focused on planning for safety and reducing kind of like risky behaviors, as well as, increasing mindfulness and like the ability to sit with really difficult memories and experiences. That was developed by Marsha Linehan. And I name these three different modalities, one, because they're all very different from each other. And I think you, with survivors of trafficking, sometimes have to throw things at the wall and see what sticks, because it is such an individual kind of experience. And two, because these modalities emphasize the processing of the life surrounding the traumatic memories over the actual traumatic memory retrieval and processing, which is going to be key for working with trafficking survivors, because it's really hard to do traumatic memory processing for survivors. It can be extremely painful. And even with folks that survivors might trust, it might be really hard for us to share just what those experiences were that we went through. So let alone sharing it with a therapist who you've known for, 6 months, 3 months, however long. Some other promising treatment approaches include trauma-informed stabilization treatment. This was also developed by Janina Fisher. Some overlap with IFS. It's a lot more intensive, though. It can be used alongside dialectical behavioral therapy. And this is being piloted in Australia and I believe New Zealand right now, and has shown a lot of promise with survivors of severe childhood trauma, including child trafficking. So as that's being researched, I think just something to keep on our radar as like a intervention to use within residential services. There's also the multimodal social ecological approach, which places a person in their environment. This can be really helpful for survivors of trafficking who do not have a centralized community or who are looking to build a community beyond their trafficking experience. And so, you place the person in the environment, you see what resources exist around them, and you start to develop those kind of networks of care. And this can include services that the person either is accessing currently or would like to access as part of their longer-term treatment. Great way to build in some treatment planning into your therapeutic approach. And then strategic care networks and partnerships. This is not really a modality of treatment, but I think this is something that, as we are looking towards other models, other treatment models to use with the survivor population, this is just something that we should always keep in mind. What this means is you have your team of professional staffs, right? We call this a care team oftentimes. So you have a person who maybe works at a hospital, who has specialized training in human trafficking. You have a person in a residential setting who works with survivors, maybe an outpatient therapist who the person is also working with, and then maybe you have someone at a shelter who can help triage. And these people are all talking to each other and meeting regularly outside of the service provision. But because those relationships are already established, you don't have to reinvent the wheel every time you want to make a referral. And I think this is really promising for those of us who have worked in direct service before, who have gone through the very common experience of, I'm going to call the hospital and see who picks up tonight. And maybe it'll be that person that I know really well and that I trust, or maybe it'll be somebody random who just started working there and doesn't even know what patients are in the hospital tonight. So this just helps streamline things and also ensures that folks working in these settings have adequate training in order to respond to the services that are needed and the needs of the population. Okay, so that was also a good chunk of information. And I hope that was helpful in terms of illustrating what treatment options are available to us now. Like I said, we don't have to reinvent the wheel. There's a lot out there that we just, aren't trying on a large scale that I think deserves to be explored further. So I'm going to move into talking about liberation psychotherapy now, and the incorporation of a public health approach within our service provision. So to define what a public health approach is, I'm going to pull from the National Survivor Network. A public health approach to violence prevention is an effective way of ending violence by focusing on the health, safety, and well-being of the entire population. rather than a focus on individual instances of violence and punishment for crime. So again, we're really focusing on collective strengths, on resources that survivors already have access to. And some of us might have heard, like a deficit-based model, which is what we tend to operate in, especially in the direct service world. This is more of a strengths-based model of what resources are already there and how can we use those resources to further enhance the quality of life and well-being of the survivors that we are serving. So the Liberation Health Model is an assessment tool that was developed pretty recently by a woman named Martinez, who is faculty at Boston University, as well as a scholar named Anastasia Fleck-Henderson. So this is an assessment tool. It's a way to conceptualize problems experienced by individuals within a larger context of society. It's also a method of practice that allows individuals, families, and communities to begin to respond to their material conditions in meaningful ways. The Liberation Health Model is not a tool that exists in a vacuum, right? When we're thinking about service provision, we also need to be thinking about the modalities of treatment that we just discussed, as well as what we're already using in our clinical settings. So we also don't want this to be an individualized process. The Liberation Health Model is meant to put the person in their environment. And so there's going to be a lot of other people who are surrounding the person you're serving. And that's always important to acknowledge because, again, nothing exists in a vacuum. And when we're talking about long-term healing from human trafficking, one of the best things we can do is increase or enhance the social networks that already surround the person, because healing happens in community. We know this. It's also not a solution to the problems that contribute to experiences of human trafficking. Like I said, there's not really any solution. I don't have a solution. Unfortunately, I wish I did. And the solution is not going to come from just one person, but this is also a way to begin to conceptualize solutions, which I think is really important as we move into more strengths-based kind of treatment. So this is a template for the Liberation Health Triangle that you can use in your own practice. I'm also going to talk us through kind of a case example of this as well on the next slide. But just to illustrate some of the components, we have our problem illustrated in this very small triangle here. And because this is solutions focused, the problem is actually going to be the smallest part of the triangle. So we're really wanting to keep this to like a sentence, 2 sentences, to really just get at the heart of like, what is the issue that we're looking to address. Surrounding the triangle are going to be personal factors. This can include experiences that might bear significance within the service provision, relevant past or current life factors, any aspects of daily life, including important relationships, living situation, work or school involvement, involvement in any other services, anything that is relevant to how the person is showing up every single day in their own life. We also include cultural factors at the bottom right. And this can include aspects of self related to culture and identity, which may include race and ethnicity, sexuality and gender, religion, language, other beliefs. At the left here, we have institutional factors. This can be any involvement with institutions, systems, and persons of power that might impact daily life and/or service provision. It could also include any people that are relevant, points of contact within those institutions. And then on our far left side, we have action steps. So this is going to be the steps towards solving the problem that was identified in the center triangle. We also want to specify here any care coordination needs, so feedback loops, providers who might be helpful to discuss further with if they're already part of the conversation or who you want to bring to the table, and any necessary social services that you might also want to bring in. So we'll talk through a case example now. So this is my composite person, April. So this is based off of, folks that I have worked with in my own clinical practice. And the problem that we've identified is that April is unhoused, lacks, a permanent residential address. So some of the personal factors identified here are that April has lived with her friends and in her car for the last 5 months that she's been unhoused. She had an experience of trafficking by her foster parents from age 13 to 17. She's a part-time student and works, around 20 to 30 hours a week at a part-time job. And she also has a psychiatric disability that she receives some services for. Cultural factors include that she is mixed race. She's white and Latinx. She has a current relationship with her bio mom. So outside of the trafficking foster family situation, has that relationship in place and is, feeling pretty good about it. And she identifies with the queer community, and that's kind of her chosen family. Institutional factors are, this involvement with child welfare starting at age 11, and, obviously extensive trauma history within that. And she has a current involvement with small claims court, which is impacting her credit, which is, adding to the difficulty in finding some long-term housing options as she works to get that cleared up. So some of the action steps that we can identify based on the information listed here, and you're always going to want to fill this out with the person that you're serving, and you can even show them and say like, hey, is this accurate? Or what do you think we need to include? Who are the people that you want on here? What is going to be helpful for you? What are your goals? So that when you develop the action steps, you're working with the person that you're serving to identify what is going to best help them in addressing the situation that you've identified. So, after talking with April, we decide we want to establish weekly meetings to discuss housing goals and just see, what the progress has been. Collaboratively developing a list of at least 3 safe housing options for, short-term shelter, whether that's also with friends or in some sort of shelter program service. And we also want to identify at least 3 people that April can call if any safety needs arise. So all 3 of these steps are going to include April in the process, right? Like, we're not making any decisions on April's behalf. We are incorporating her perspective into the services. So you also want to make sure that the action steps are tangible and aren't just like, it's not a laundry list of things that you're going to have to do with the person. And that can really quickly become overwhelming. So we want to think of this like we think of treatment goals, right? Where we want to pick things that are going to be feasible within our services, but that also benefit the person that we're serving in the way that they most need and want. So to conclude this section, regardless of treatment modality, human trafficking is a complex public health issue that requires a multifaceted approach to address, right? And when we're thinking about solutions, clinicians alone are not going to have all the answers. Our work is important to building lasting solutions, but if you take away anything from this presentation, please take away that this doesn't happen in a vacuum. And we need service providers of all types to really be in on the conversation, and we need to be talking to each other. That's going to be how we develop the long-term solutions, is by bringing all perspectives, including survivor leadership, people with lived experience, and people who have lived and professional experience working with trafficking survivors to the table. So to conclude this presentation, clinical concepts related to complex trauma, including betrayal trauma and structural dissociation, are essential for us to understand when working alongside survivors of human trafficking. Just to kind of summarize some of that theoretical stuff up. And I would encourage you all, if you're interested, to keep exploring some of those clinical concepts. I found it personally very helpful in my own professional work to have a good grasp on those, and to really understand kind of what's happening from a macro psychological perspective. We also want to remember that long-term service provision should be emphasized in the clinical setting over short-term options in these graduation models of services. And we really need to start thinking about, how do we get long-term services funded, and what does that look like when we are, applying for grants or we're trying to get funding for our programming? How do we build in lifelong services into those models. Lastly, while there's currently no identified best practice for survivors of trafficking within the clinical setting, there are a lot of promising practices that we can draw from when providing services. And there are also things that we can use, liberation health model tools that we can use to help conceptualize what services we need to be using with folks. So that concludes my presentation for today. If you have any questions, or would like further resources, feel free to email me. My email is listed on this slide, and we can move into some Q&A, and I will just quickly take you all through my reference slides. There are a lot of them, because there is a lot of great work already being done on these topics. So thank you so much for attending today's session, and I will move into taking questions.